Okay, 5, 4, 3, 2, 1. Next. Good evening, everyone. We welcome you all to Ortho TV Online in association with OREF. To introduce today's speaker and topic, I hand over to our chairman, Dr. John Mukhopadhyay.
Good evening, everybody, and welcome to this evening's webinar. This is going to be brought to you by Dr. Rajeev Ranjan, one of our young dynamic consultants in Parasech MRI, and he's going to discuss shoulder instability. So, approach to shoulder instability, how do you diagnose it, and then how do you manage the problem in different situations. So over to you, Rajeev.
Thank you, sir. Good evening, everyone. Shall I start sharing my presentation?
Yes, please.
Yeah, thank you, sir. Oh, am I visible and audible?
Yes. Yes.
Yeah. Thank you, sir. Good evening, everyone. Today we are going to discuss the approach to shoulder instability. So first, coming to some of the basics of shoulder joint, it's a ball and socket joint with 3 degrees of freedom of movement, like the flexion, extension, abduction, adduction, internal and external rotation, along with the circumduction. This joint has a very high range of movement, but this increased mobility comes at the cost of instability. The relative size of humeral head is almost 3 times larger than the glenoid fossa. And so what's the instability? During the use of a normal shoulder, the humeral head is centered within the glenoid and the coracoacromial arch. Inability to maintain this centered position is called as instability of that shoulder. But it's not the same as the laxity of the joint, because in the laxity, it allows the joint the full range of functional positions, while an unstable shoulder prevents the normal function of that extremity. So in the laxity, the normal function will be maintained of the joint, but in instability, the full functional range will not be possible for that joint. So what are the factors which are responsible for maintaining the stability of the shoulder joint? It has been divided conventionally into the static and the dynamic factors. The static ones are the articular congruence, the articular version, the retroversion of the humeral head and the glenoid, the fibrocartilaginous tissue, the glenoid labrum, and the capsule and the ligaments. The dynamic ones are the rotator cuff muscles, the biceps tendon, the scapulothoracic muscles, and the scapulothoracic movements, negative intra-articular pressure, which is around minus 40 mm of water, and the proprioception of the joint. Osteology, we have already said there is 7 degree of retroversion of the glenoid fossa and the 30 degree of the retroversion of the humeral head. Glenoid labrum, which is a fibrocartilaginous tissue, it provides the 20%, it's responsible for the 20% of the glenohumeral stability. It increases the supero-inferior proximal distal diameter of the shallow glenoid by 75% and the AP diameter by 50%. It deepens the glenoid by 50%, so it has a major role in increasing the surface contact area of the glenoid cavity. It produces a buttress effect, and it also provides the attachment site for the glenohumeral ligaments. The important ligament is the glenohumeral ligament. There are 3 glenohumeral ligaments: the superior, the middle, and the inferior ones. The superior is an important check at 0 degree of abduction. The middle one is at the mid-range of abduction, whereas the inferior glenohumeral ligament is an important check at more than 45 degree of abduction of the shoulder joint. In the photograph, this one is the superior and this is the middle and the inferior glenohumeral ligaments. Rotator cuff muscle, we all know these are the supraspinatus, infraspinatus, teres minor, and the subscapularis. The movement of these rotator cuff muscles contribute to the negative intra-articular pressure of the shoulder joint, and these muscles make a protective cuff all around the shoulder except inferiorly where the capsule is the weakest. So what is the pathoanatomy of shoulder instability? It could be because of the lesions in the labrum or the capsule or the bone loss. The labral lesions are included. Some of the labral lesions, the most common is the Bankert, the reverse, which is seen in the posterior instability, and the slap lesion. And the capsular injury, we can see the intrasubstance tear or the humeral avulsion of the glenohumeral ligaments, the capsular laxity. And in the bone loss could be present in the glenoid or the humeral head as heel sacs or reverse heel sacs, depending upon the anterior or the posterior instability is present in that person. Bankert lesion is the traumatic detachment of the glenoid labrum. It's present in almost 85% of the cases in the photograph. In this MRI, this slide, we can see there is detachment of the anterior labrum. This is called the Bankert lesion. In this animated part, we can ascertain it more clearly. The anteroinferior labrum is separated, and in this X-ray, most probably there is bony Bankert also present. The other lesions which pathoanatomical lesions which could be present are the reverse Bankert tear, which is in the posterior part of the labrum. Here it's the posterior part because the humeral head is retroverted and it is directed posteriorly, and so this part is showing the labral tear. So it's a reverse Bankert tear seen in cases of posterior instability of the shoulder. This photograph showing the slap tear. Slap is superior labrum anterior to posterior. This is also associated with the instability. And this is MRI, sorry, in this MRI cut, we can see superiorly there is clear-cut slap lesion, slap tear in this MRI picture. Another important lesion which is seen is the ALPSA. It's the anterior labropeliosteal sleeve avulsion. In this, what happens, the labrum gets detached along with the intact periosteal sleeve, and this whole complex sits medially to the glenoid labrum, and in that position it unites, and which is the non-functional position for that part of the glenoid. So this is important to note, because if you are going for the management of this, then you have to lift it up and to align it to get the proper correction of the instability. Hill-Sachs lesion. This is a defect in the posterolateral aspect of the humeral head. In this photograph, we can see after the shoulder is dislocated, the posterolateral part of the humeral head abuts against the glenoid, and that may create an impression or defect in that part. After the reduction of the joint, we can see there is a defect in the posterolateral part of the humeral head. That is called the Hill-Sachs lesion. In this MRI, slide, we can also see there is the defect in the posterolateral part. CT scan depicts the best. We can also quantify that. The normal AP X-ray can also show the Hill-Sachs lesion. So how do we classify this shoulder instability? It can be classified on the basis of the frequency, etiology, direction, and degree. It has been suggested by the Warner in 1997. On the basis of frequency, it could be the acute, recurrent, or the chronic one. Or on the basis of the etiology, it could be because of the macro trauma, the traumatic one, or the atraumatic one, because of the repetitive micro trauma which is seen in the athletes, or because of the congenital conditions or neuromuscular conditions. On the basis of direction, it can be classified into the anterior, posterior, inferior one. Anterior is the commonest one, and inferior is the rarest one, and another is the multidirectional. On the basis of degree, it is classified into the dislocation, subluxation, or the microtrauma, the transient dislocation. But the most commonly used classification is the Thomas and Matson classification. It divides into two types of dislocation. One is the instability, one is the TUPS, another is the AMBRI. The TUPS stands for the traumatic etiology is traumatic, it's unilateral, associated with the Banquet lesion, and for management surgery is often necessary for this condition. The AMBRI stands for atraumatic, multidirectional, bilateral, and the primary line of the treatment is the conservative, that is the rehabilitation. And if the surgery is needed, the inferior capsular shift is the most preferred surgery for that condition. So, how do we evaluate a patient of instability? First, we go for the history. The age. Age is the most important factor determining the chances of recurrence of this shoulder dislocation. Another is the trauma duration, since the trauma associated pain, in what type of a sport that person is involved, whether the presence of voluntary subluxation is there or not, that what are the limitations of movements, what was the energy associated with the dislocation, when the first dislocation has occurred, and what were the number and the conditions during the subsequent dislocations, or only the further episode only the subluxations were present in that case. After the history, coming for the physical examination, like any orthopedic condition, how we follow the pattern of look, feel, move. After that, we have to see for winging, and you have to do the neurovascular testing. And if it's multi-directional like AMBRI, then you have to look for the generalized ligamentous laxity, and you have to perform some of the instability tests. So how, if a patient presents with the anterior dislocation of shoulder, how he presents? He will be having that arm abducted and externally rotated, and the patient will hold is the affected arm with the opposite hand, and there is a loss of rounded contour of that shoulder. In case of posterior dislocation, like we can see in this condition, the right shoulder is having the posterior dislocation. The patient presents with a position which is called sling position. That is, there will be adduction and internal rotation of that shoulder. And similarly, the patient will be holding the affected arm with the opposite hand. And there will be posterior prominence of the shoulder. The lowermost photograph shows the rarest type of dislocation, that is the inferior type, that is also called the luxatio erecta. It has the highest association with the neurovascular injury around the shoulder. So coming to the clinical test, the provocative test, that is the crank test or apprehension test, is performed in the sitting position at 90-degree abduction of the shoulder and 90-degree flexion at the elbow. With increasing external rotation, the examiner exerts anteriorly translatory force from the posterior side and watches for apprehension. If the apprehension is present, it's diagnostic of the instability, but if only the pain is present, it indicates that there is only subtle subluxation. Another test is the mid-range instability. It's performed, it's like that the apprehension test, but it's performed only at the 45-degree abduction instead of the 90-degree. And on increasing external rotation, even at this abduction, the patient will have apprehension. This test indicates the presence of some of the bony lesions in that patient. Job's relocation test. In this case, we have to repeat the apprehension test and note the amount of external rotation at the shoulder needed to produce the apprehension. Then a posteriorly directed stress is applied over the humeral head, and that external rotation maneuver is repeated again. And then we note the difference in the range of external rotation for producing the apprehension. If after the posterior stress, the range of external rotation increases, it indicates the positive test. And also, if the apprehension reappears on release of this posterior stress, that is called the release test. If it's present, this also indicates the positive test or the presence of the instability in that shoulder. Fulcrum test. It's performed with the patient lying supine with the scapula supported by the edge of the table, and then the arm is positioned in 90-degree abduction. And with increasing external rotation, the examiner watches for apprehension. If apprehension is present, this test is also positive. Hamilton ruler test. This is present in cases of dislocation. In this test, the ruler, after touching, if the ruler is touching the lateral epicondyle, it does not touch the acromion. But in case of dislocated shoulder, the ruler will simultaneously touch the lateral epicondyle and the acromion. Sulcus sign. On pulling down the arm, if the gap between the lateral end of the acromion and the humeral head increases by more than 2 centimeters, then it's considered positive. Load and shift test is the quantitative test, and it's performed by the examiner stabilizes the shoulder from the behind and grabs the humeral head, and it pushes anteriorly and then posteriorly. If the shift is anteriorly, the shift is more than 30% of the humeral head diameter, then it's considered as the presence of the anterior instability in that shoulder. And if the 50% more than 50% shift is present on the posterior side, then the posterior instability presence is confirmed. It's a quantitative test. Jerk test. This test is done to mark the presence of the posterior instability. In this there is 90-degree abduction of the shoulder, and there is internal rotation, and slight flexion is present, and posteriorly directed axial force is applied. If there is posterior inferior subluxation is present, or patient feels there is subluxation posteriorly, then this indicates the posterior instability of that shoulder. If there is presence of ambry condition, then you should look for the presence of the generalized ligamentous laxity. The diagram and the photograph shows the test used for the Beaton score, and you have to look for the presence of this generalized laxity in such patients. If there is presence of voluntary subluxation, or there is multidirectional instability in that patient. After the clinical test, we go for the investigation. The investigations commonly which we perform are the X-rays, CT scan, and MRI. The AP X-ray shows the humeral head and the glenoid, and there is slight overlap of the humeral head over the glenoid cavity. The true AP shows without any overlap of the humeral head and the glenoid, and we can ascertain any defect of the humeral head or the glenoid by that X-ray. Auxiliary view helps in assessing the presence of the humeral head, whether its presence anterior or posterior to the glenoid in case of dislocation or in case of laxity. This slide shows the AP view in the internal rotation, neutral rotation, and the external rotation at the shoulder joint. This all shows the Hill-Sachs lesion. If the Hill-Sachs is seen even at the external rotation of the shoulder, then it's a significant Hill-Sachs, and it also shows the presence of the superior humeral bone loss. Striker notch views shows the presence of the defect in the posterolateral part of the humeral head, that is the Hill-Sachs lesion. CT scan provides the maximum information and also provides information for the planning of the further management of that patient. 3D CT scan, 3D reconstruction CT scan provides the maximum information regarding the Hill-Sachs and also the presence of any defect in the glenoid. And this 2D coronal cuts of the glenoid helps in measurement of the glenoid bone defect. In this photograph, we have shown the best fit circle method for the measurement of the glenoid bone loss. This is important for the planning of further management. This slide shows the newer concept of the off-track and the on-track lesions of the humeral head. Previously, it was engaging and non-engaging, but this concept has been modified by the Burkhardt in 2014. as the off-track and on-track lesions. This glenoid tract concept has been given by the Itoi et al. In 2007. This glenoid tract is the 83% of the glenoid width, and during the movement of the shoulder joint, if that Hill-Sachs lesion does not engage or the it lies within that glenoid tract, then this is called on-track lesion, and it does not need any further added management for that instability. But if that Hill-Sachs lesion falls outside that glenoid tract, this is called off-track lesion, and it needs management of that Hill-Sachs. This is the arthroscopic photograph showing this Hill-Sachs is getting engaged in the glenoid defect. On the basis of this off-track and on-track lesion, treatment paradigm has been suggested by the Giacomo et al. For the management of this shoulder instability. If the glenoid defect is less than 25% and the Hill-Sachs is on track, then only the arthroscopic Bankart will suffice for the management of that patient. But if the defect is less than 25% and the Hill-Sachs is off track, that is, it's engaging, then along with arthroscopic Bankart, you need Remplisa. Remplisa is just filling up that humeral head defect with the infraspinatus tendon. And if the glenoid defect is more than 25%, then even if the Hill-Sachs is on track, we need to do some bony procedure. And Latarjet is the most preferred bony procedure for such condition. And if the glenoid defect is more than 25% and the Hill-Sachs is off track, then along with that bony procedure, you also need to do the Remplissage or the humeral bone graft of that defect. One important scoring system which is followed for the planning of management in the instability severity index score. It considers the questionnaires and the clinical examination and the radiographs. This score also considered age as one of the most important factors. If this score is having 6 or less points, then there is acceptable recurrence risk of Bankart surgery, arthroscopic Bankart surgery, that is less than 10%. But if the score is more than 6, then it has a very high unacceptable recurrence risk of 70%, and the patient should undergo some open surgery, mainly bony surgeries. Another recently introduced scoring system has been used, and that is glenoid tract instability management system, GTIMS. It's the modification of this ISIS, just it includes the concept of this off-track and on-track lesions of the humeral head and the glenoid. This by using this scoring system, the threshold for doing bony procedures have increased. In other terms, the success rate of post-operative outcome of the arthroscopic Bankart surgeries has improved. So coming to the commonest dislocation, that is the anterior dislocation, it's the 95% of the total dislocation, shoulder dislocations, and 97% of the total recurrent dislocations. It is produced in the abduction, extension, and external rotation on the shoulder. There are 3 types: the subcoracoid, subglenoid, and the subclavicular. The subcoracoid is the commonest one. The associated injuries are the head and neck fracture and the rotator cuff tear, which is if in more than 40 years is present in 30% of the patient, that in 60 in elderly patient which more than 60 years are the chances of presence of rotator cuff tears are 80%. So the neurological injuries are the commonest one are the axillary nerve, and the incidence is 10 to 25% is in the first time dislocation, but in recurrent dislocation it's only 2 to 5%, and treatment is just a watchful expectancy. But if it doesn't recover by 10 weeks, chances of recovery is poor. Vascular injury is very rare, but if it is present, it's of axillary artery or the second part of the thoracoacromial trunk. Treatment. The non-operative treatment includes the close reduction and the immobilization in the sling in internal reduction and internal rotation position, analgesics, and the gradual rehabilitation range of movement exercises. Acute dislocations are managed in the emergency by one of these three methods. That is the Stimson. The first one is the Stimson, and the Hippocratic methods and the Coccus methods. Anyone can be used for the reduction of the shoulder dislocation, anterior dislocation of the shoulder. The treatment of first-time dislocators is a debatable topic. There are two groups which immobilizes the shoulder for 4 weeks. Then in that cases, the recurrence rate is up to the 80%, and the recurrence rate after the surgical repair is just 14%. The non-operative treatment, so only the non-operative treatment has only the 16% traumatic cases respond to the non-operative one, and the AMBRI, the atraumatic ones, 80% of them respond to this conservative treatment. If surgical stabilization is needed, then the open or arthroscopic surgery can be done for the anterior dislocation. The surgical treatment are done to address the pathological changes in that joint responsible for the instability. The capsulolabral repair can be done, that is the Bankart or the modified Bankart procedure, the subscapularis procedures, or the coracoid transfer procedure, that is the Boni procedures, that is Bristow or Lutter's. Arthroscopic Bankart repair, and the first photograph shows that there is the separated labrum from the glenoid, and the subsequent photograph shows the passage of the suture through the capsulolabral tissues, and then that fixation with the anchor placed on the face of the glenoid. And in the last photograph, we can see there is a good bump anteriorly, which provides the stability to that patient. Modified Bankart is an open procedure, and that in that plication of the capsule is done. The Boni procedure, which is the most commonly performed nowadays, is the Latarjet procedure, in which the coracoid is taken off along with the short head of the biceps, and that is passed through the subscapularis and inserted over the anteroinferior part of the glenoid. This procedure provides both the static and the dynamic stability to that shoulder, static by the bone graft and the dynamic by the attachment of the tendon over that coracoid piece. This procedure has a very less failure rate of less than 3% in properly selected cases. Posterior dislocation is less than 5% of all the dislocation, or 3% of the recurrent dislocation. It's also of 3 types: the subacromial, which is the commonest one, of the subglenoid, and the subspinous. This X-ray shows the posterior dislocation with the classical light bulb sign, which is present in this case. Sorry, the mechanism is the axial load of the arm in the flexed or adducted position, or during the bench press, or in the swimming, or during the rowing, or in contact sports. This can be seen because of the direct posteriorly directed force over the shoulder. The examination part includes that a shift and load test, which we have already discussed, the posterior apprehension test and the jerk test. Investigations include the same, the X-ray, the CT, and the MRI. What we get in that, we have already seen that the reverse Bankart or the reverse Hill-Sachs lesion in such cases, or that ALPSA, the counterpart of the posterior counterpart of the ALPSA is the POLPSA, posterior labral periosteal sleeve avulsion, is seen in such cases. The treatment is mainly the immobilization, rehabilitation, and 70 to 90% patients improve by this treatment protocol. If at all operative management is needed, the success rate is varies from 50 to 90%, 95%, and there is relatively higher recurrence compared to the anterior instability procedures. Some of the soft tissue procedures are the posterior capsulorrhaphy or the reverse Putty-Platt. In Putty-Platt, what we do is the embracing that subscapularis, and the reverse Putty-Platt, we do the infraspinatus capsular tenodesis. In this last, this inferior, the lower photograph shows the McLaughlin's procedure, in which the anteromedial defect of the humeral head has been filled by the subscapularis. the bony procedures which are done for this posterior instability are the posterior glenoid osteotomy or the posterior bone block. The rehabilitation protocol is the immobilization for first 4 weeks, no external rotation, abduction should be less than 45 degrees, isometric resistance exercises, and then gradually after 4 to 8 weeks, ROM exercises are started. Sports can be started after 6 weeks, but the contact sports are started after 3 months. So that about the instability, that shoulder instability. The commonest thing which is a matter of debate whether to operate the first time dislocator or not is still a debatable issue, and mostly most of the studies nowadays are in favor of operating the first time dislocator if it is the injury is significant or the age of the patient is lower. These all 4 studies favors the age as the primary risk factor for recurrent instability. If it's more than if it's less than 20%, then almost 90% chances of recurrent dislocation is present in such patients. And there are pros and cons of that. If we operate the first time dislocators, then it prevents the early recurrence, but the effect is we may fix the 10 to 40% of the shoulders which would have not have recurred. The another part, if we fix them late after the recurrence to avoid operating on such patients, then that chronicity may lead to further injury like the slap lesion or abscess lesion, other lesions. So this was published in the arthroscopy journal. So this is a matter of debate that I have just put for my interest for the discussion. So that's all my presentation. Thank you all for your patient hearing. Thank you, sir.
So we have a few questions in the chat box, sir. One thing what Gautam has asked is what is the difference between recurrent and chronic in terms of number of episodes?
Nowadays, recurrent is just even the second episode is considered as a recurrent. Chronic, exactly definition, if it is persistent every time, there is no exact such type of number of dislocations defined for such dislocation. If it is fixed, the head is dislocated anteriorly, then that is called chronic. And recurrent is every time it is dislocating and we are reducing, whether the patient is able to reduce it himself or the doctor is reducing. And chronic is it's fixed in that position. That's why that chronic is also called as the fixed dislocation.
Another question what he has asked is about mild range apprehension test. When
Mid-range.
it is a mid-range apprehension test, then which type of bony lesion you can expect?
That both the glenoid or mainly the Hill-Sachs lesion, that is the off-track lesion, what we have discussed already. That off-track lesion which is getting off the glenoid track, that Hill-Sachs lesion is getting off the glenoid track, means that is getting engaged with that defect. Mainly that type of lesion produces that clinically that mid-range instability in such patients.
So what is the difference between off-track and on-track?
I've shown that in slide. Off-track, suppose glenoid, it's imagine the glenoid, the whole glenoid weight, the 83% of that part is considered as the glenoid tract. This concept was given by the Etoy. So if the Hill-Sachs lesion, that posterolateral part of the humeral head defect, if during the movement that part is not lying over, it is lying totally over that glenoid tract, it means it not going out of that tract, then there will not be additional instability because of that effect, and you will not have to do anything extra like what we are doing the Ramplissage, or in more severe cases that bony procedures. You don't need to do that. But if it is getting out of track, that defect is so big, that humeral head defect is so big that it's during the movement it's coming out of the glenoid tract. So for that you need to address that defect also. That is the off track and on track concept given in 2014 by the Burka. Initially it was also it was almost similar to the engaging and non-engaging lesion. It almost same. The engaging is the off track and the non-engaging in the on track lesion. It's a similar type.
He has asked about in one question that in case of instability, when to think for CT scan. Usually we go for an MRI. So when you used to take
but the first investigation for any case we go for X-ray. If on X-ray you are suspecting there is some bony defect, like I have shown in my presentation, clear cut, you can see that Hill-Sachs lesion, and also in some of the cases the bony glenoid and bony Bankart you can see. If on X-ray you are suspecting, or on the clinical examination you are getting the mid-range instability, in those cases you should go for the CT scan on that shoulder.
And the Sumit question has already answered. And another one from Sachin is, what is Victor's total scoring? How to measure?
That photograph itself shows that thumb and the little finger, and that hyperextension at the elbow and the knee, and whether you are able to touch the floor in extension of the knee with the palm. That is, total score is 9. If it is more than 4, then it is considered generalized ligamentous laxity.
So there are 2 scoring which is given. One is this one, and one more is there. I think we should go by the book. Yeah. And in Ambry, that I stands for that internal
inferior capsular shift.
Inferior capsular shift. So
inferior capsular shift. What we do, we give a T-shape incision, the vertical limb over the glenoid part and the horizontal limb over the capsule. It's all over the capsule, but on the capsule over the glenoid part, and in the horizontal part between the humerus and the glenoid. And then we lift this inferior part proximally, and then we imbricate it. That is the plication. It's like a plication. So just we decrease the total volume of that capsule. So we just shift the inferior, because the laxity is mainly present in the inferior part. We shift the inferior capsule proximally. So we decrease the volume of that joint, and that capsule is getting tightened. That is inferior capsular shift. Oh, I have not shown that in a photograph. It was there.
Okay. So, and one more thing, you have shown so many tests. So for a postgraduate, which one is important for examination point of view? Because there are so many tests in shoulder joint in different groups.
No, see, depending upon by history, you can ascertain which is the anterior or the posterior one, the instability. So apprehension test you should do, you must do that, and that job relocation test. That is that can be performed easily by any postgraduate. And if you are suspecting the posterior one, then jerk test, that is also not so difficult to perform. These 3 tests can be easily performed by any postgraduate.
And one more thing is about the some surgeries which is actually anatomical, keeping anatomy in the mind, and most of the surgery that is non-anatomical. So can you just few names and which one is important so that?
Anatomical surgeries means, see, what we have to address, what is the pathology. If it's a soft tissue pathology like the Bankart, we have to address that only. It's not like that bony procedure will be helpful in all the cases. If there is defect only in the labrum, we have to fix that by that Bankert procedure, what we do. And if there is defect, is bony defect, what criteria we have already seen, that glenoid bone defect and the Hill-Sachs is off track or on track, or there is that instability severity index score. With those criteria, if you are following, we should go for the surgery which is needed, rather than bony procedure like rotational procedure and then Magnuson stack and all. These are very less frequently performed nowadays. Mainly they are doing that also we are doing that arthroscopic Bankert, or we go for that Latarjet. Nowadays Latarjet is also performed arthroscopically, but that is the bony procedure. And that is anatomical, mostly anatomical, because we keep that graft. That is a totally altogether a different topic. The Latarjet itself is a separate topic for discussion. So that bony graft, how we are positioning that also decides, because if you are protruding it laterally, that causes early arthritis in the shoulder. If you are keeping it too medial, it will not serve the purpose. So we have to keep in mind the anatomy, the normal anatomy of the shoulder. We have to restore the normal anatomy of that shoulder. So that can be decided only by the identifying the pathology in that shoulder.
What are the open procedure? Like a Latarjet is an open surgery. It cannot be done.
Yeah, Latarjet is mostly done
also,
open.
but it's mostly done open. There are few people who are doing it arthroscopically as well. It's a little technically difficult to get it right arthroscopically, but there are people who do it arthroscopically as well. And the open procedures, there's a whole lot of them, starting from good old putty plat to Bristow to. So what's the difference between a Bristow and a Latarjet?
Sir, in Bristow, what we do, we detach the coracoid and then we reinsert it through the subscapularis and we reattach it with the coracoid. And in Latarjet, what we do, we just attach that coracoid portion with the anterior glenoid part. This is the difference between Bristow and
Coracoid,
coracoid, if you are we are attaching the coracoid over the anterior glenoid along with that tendon, that is Latarjet procedure. And if we are reattaching the coracoid after passing through the subscapularis, and we pass that coracoid portion with the subscapularis and reattach with that coracoid portion, and that is Bristow. What we used to do during our PG time, we were mostly using this one. But nowadays we are doing the Latarjet.
And one more thing, which is I think one quite famous classification where I think Stanmore has described one triangle. On that one, that is a little difficult to understand. Polar type 1, 2, and 3. He has classified. So in that one, he has shown one muscle patterning. So what is that actually in that classification? How to understand that? They have one triangle on which one they have put polar type 1, 2, and 3. And he has taken 3 things in that. One is trauma, that in polar type 1 it is traumatic.
Traumatic structural, atraumatic structural, and muscle pattern is difficult to explain.
Yeah, that is, I think that is because even for the examination also, we have just remembered that thing, that triangle we have to draw.
Yes, but clinical application is list, so you forget that part.
Okay. So this one, I think most famous one is Ambry and Tubbs, which the DNB should remember that one. So in Ambry type, when you go for surgical procedure, because you have explained that most of the thing is by conservative means.
80 to 90% cases, 55 to 90 exactly, that they respond to the conservative treatment. What if it is not responding, the dislocation or the instability is persisting? In that case, we are forced to go for the surgery. And that if we are going for the surgery, the first preferred choice is the inferior capsular shift.
So think for DNBs, yeah.
So if no further questions, we'll call it a day.
Yes, most of the things we have. I think there is no question from the DNBs now. So
good. So, okay, then thank you very much, Rajeev.
Thank you, sir.
I'm sure the DB students and the postgraduate students should have found that useful. And until next week, we'll call it a day today. And thank you, everybody. Okay.
Thank you so much, sir.
Bye.
Thank you, sir.
Thank you, sir.
Bye.
Thanks.
So Janki, within time it has been done. You were worried, I will take more time. Okay. Thank you so much. Okay, bye-bye.
Thank you, sir.
Okay, bye-bye. Bye.